Hello, everyone. Before we start, make sure to like and subscribe to the channel and leave a comment with where you're from and what time you're watching. That way, YouTube will keep showing you stories just like this one. Now, let's begin. I'm a trauma surgeon at Memorial General Hospital in Portland, Oregon. Or at least I was until I submitted my resignation last week. You can call me Dr. Sarah Chen if you want, though most people in the trauma bay just called me surgeon during my 8 years there. I've seen everything you can imagine in trauma surgery. Car accidents, motorcycle crashes, construction site injuries, industrial accidents, and every kind of catastrophic damage the human body can survive. But what I'm about to tell you about is the one case that made me question everything I thought I knew about human anatomy and ultimately led me to leave surgery entirely. Memorial General is a Level 1 trauma center serving the entire Portland metropolitan area and much of Southwest Washington. It's a massive facility built in the early 2000s with a state-of-the-art trauma unit that handles over 3,000 critical cases per year. During my time there, I specialized in thoracic trauma, working primarily with chest injuries, lung damage, and cardiac emergencies. The kind of cases where every second counts and the difference between life and death often comes down to how quickly you can get someone into an operating room. My first day as an attending trauma surgeon was July 15, 2019. I had just completed my residency at Johns Hopkins and was finally ready to lead my own surgical team. After years of training, countless hours of studying, and more sleepless nights than I could count, I was about to face my first day as the primary surgeon responsible for saving lives. The anticipation was overwhelming. Part excitement, part terror, and complete determination to prove that I belonged in one of the most demanding specialties in medicine. Memorial General operates on a rotation system where attending surgeons work 12-hour shifts, either 7 a.m. to 7 p.m. or 7 p.m. to 7 a.m. For my first day, I was assigned to the day shift, which typically sees a steady flow of trauma cases, but tends to be slightly more predictable than the chaos that often unfolds during overnight hours. I arrived at the hospital at 6:30 a.m., giving myself extra time to review cases, check equipment, and mentally prepare for whatever the day might bring. The trauma bay at Memorial General is an impressive setup. 6 fully equipped operating rooms, specifically designed for emergency surgery, with advanced imaging capabilities, blood banks on standby, and teams of nurses, anesthesiologists, and support staff who have worked together for years. The efficiency of the operation is remarkable. From the moment a trauma patient arrives by ambulance or helicopter, everyone knows their role and executes it with precision that can only come from years of experience dealing with life and death situations. Dr. Michael Torres, the chief of trauma surgery, met me in the break room at 6:45 a.m. for what he called a first-day briefing. Dr. Torres had been at Memorial General for over 15 years and had a reputation for being both an exceptional surgeon and a demanding mentor. He was the kind of physician who expected perfection from his team because he knew that anything less could cost someone their life. "Sarah," he said, pouring coffee into 2 paper cups, "today you're going to see cases that will test everything you learned in residency. Some days are quiet, some days are absolute madness. The key is to stay calm. Trust your training and never hesitate to ask for help if you need it. Pride kills patience in this business." I appreciated his directness. During my residency, I'd worked with attending physicians who were more concerned with maintaining their authority than ensuring the best possible patient care. Dr. Torres seemed different. He struck me as someone who genuinely cared about both patient outcomes and the development of younger surgeons. The first few hours of my shift were relatively routine. A construction worker came in with a nail gun injury to his hand that required microsurgery to repair damaged tendons and nerves. A motorcycle accident victim needed surgery to remove glass fragments from his abdomen and repair a small tear in his intestine. Both cases went smoothly, and I was starting to feel more confident about my abilities as an attending surgeon. Around 11:30 a.m., things changed dramatically. The trauma alert system activated, and the distinctive sound of the helicopter landing on our rooftop helipad echoed through the building. Within seconds, our trauma team was assembled and ready to receive whatever critical case was being transported to us. The paramedic radio crackled with preliminary information that made everyone in the room pause and take notice. Incoming trauma, ETA, 3 minutes. Adult female, approximately 25 years old, involved in industrial accident at construction site. Patient fell approximately 40 feet through multiple levels of scaffolding before landing on concrete. Multiple trauma, unconscious, possible spinal injury, significant chest trauma. Vital signs unstable but present. This is going to be a bad one. I felt my heart rate increase as the trauma team prepared for what sounded like one of the most severe cases any of us would see that day. Falls from that height are often fatal, and when patients survive the initial impact, they typically face months of recovery and potential permanent disabilities. The fact that this patient was still alive and being transported to us suggested either remarkable luck or incredible resilience. The elevator doors opened at exactly 11:33 a.m., and the flight paramedics wheeled in a patient who immediately struck me as unusual. The young woman appeared to be in her mid-20s with long dark hair and athletic build. She was unconscious, intubated, and connected to multiple monitors that were beeping steadily but showing concerning vital signs. Her blood pressure was low, her heart rate was elevated, and her oxygen saturation was hovering just above critical levels. But what caught my attention first was not her injuries, but rather how she was positioned on the gurney. Despite supposedly falling 40 feet through scaffolding and landing on concrete, her body was perfectly aligned. No obvious deformities, no limbs bent at unnatural angles, no visible signs of the catastrophic trauma you would expect from such a severe accident. It was as if someone had carefully arranged her on the stretcher rather than her being the victim of a chaotic fall. What do we know about the accident? I asked the lead paramedic, Tom Richardson, who I had worked with several times during my residency rotations at Memorial General. Construction foreman found her unconscious at the bottom of a 4-story scaffolding structure around 10:45 a.m. Witnesses say she was working on the 3rd level when part of the scaffolding gave way. She fell through multiple levels of metal framework before hitting the ground. No one saw exactly how she landed, but the impact site shows significant blood pooling, so we know she was there for a while before being discovered. I began my trauma assessment while the nurses worked to establish additional IV access and prepare her for immediate surgery. Her pulse was weak but steady at 110 beats per minute. Blood pressure was 85/50, indicating possible internal bleeding or shock. But her respiratory effort, even with mechanical ventilation, seemed surprisingly strong for someone who had sustained such massive trauma. As I continued the examination, I began to notice inconsistencies that didn't align with the reported mechanism of injury. Her skin showed multiple abrasions and cuts consistent with scraping against metal scaffolding during a fall. But the pattern and severity of these injuries seemed too uniform, too evenly distributed across her body. Most fall victims sustain more severe injuries on one side or in specific areas where they made primary contact with objects during their descent. More puzzling was the absence of fractures. X-rays of her chest, pelvis, arms, and legs showed no broken bones whatsoever. In my experience, patients who fall 40 feet and survive typically have multiple fractures, especially in the extremities and ribs. The human body simply cannot absorb that kind of impact energy without sustaining significant skeletal damage. Yet this patient appeared to have avoided fractures entirely while still showing signs of severe internal trauma. Dr. Chen, her chest X-ray is showing some concerning findings, announced Jennifer Walsh, our lead trauma nurse. There appears to be fluid in both lung fields, but the pattern doesn't look like typical traumatic pneumothorax or hemothorax. I studied the imaging carefully, and Jennifer was right. The patient had bilateral pleural effusions, meaning fluid was accumulating around both lungs. This was causing her breathing difficulties and contributing to her unstable condition. But the location and appearance of the fluid didn't match what I would expect from blunt chest trauma. Normally, falls from significant heights cause rib fractures that puncture the lungs, creating air pockets or blood accumulation in predictable patterns. This looked different. We need to get her to OR3 immediately, I decided. She needs emergency thoracic surgery to drain the fluid and assess the damage to her lungs. Whatever happened to her, She's not going to survive without immediate intervention. The surgical team assembled quickly, and within 15 minutes, we had the patient prepped and draped for surgery. As I made the initial incision to access her chest cavity, I was expecting to find the typical damage associated with high-impact trauma: torn lung tissue, damaged blood vessels, possibly fragments of broken ribs that had lacerated internal organs. What I found instead challenged everything I thought I understood about trauma surgery and human anatomy. The patient's chest cavity contained approximately 800 milliliters of fluid, which was significant enough to cause her breathing difficulties and circulatory problems. But the fluid wasn't blood, as I had expected. It wasn't the clear yellow fluid typical of traumatic pleural effusion either. The fluid was unlike anything I'd ever encountered in 8 years of surgical training and practice. It had a slightly iridescent quality, almost shimmering under the surgical lights. The consistency was thicker than normal pleural fluid, but thinner than blood. When I collected a sample for immediate analysis, it felt unusual even through my surgical gloves, as if it had properties that didn't conform to normal biological fluids. "Dr. Chen, this is highly unusual," commented Dr. Lisa Park, the anesthesiologist monitoring the patient during surgery. "Her vital signs are actually improving now that you're draining the fluid. Heart rate is coming down, blood pressure is stabilizing. It's almost like removing this fluid is having an immediate therapeutic effect." That was medically significant. Normally, draining fluid from around the lungs provides some relief, but the improvement is gradual as the patient's respiratory function slowly returns to normal. This patient was showing rapid, dramatic improvement that seemed disproportionate to the amount of fluid we were removing. As I continued the surgery, examining her lung tissue and internal structures, I found more anomalies that defied medical explanation. Her lungs appeared to be completely healthy, with no signs of trauma, contusion, or damage that would be expected from a fall of this magnitude. The tissue looked perfect, pink and well perfused, as if she had never experienced any kind of chest trauma at all. Her heart appeared equally pristine. I examined the cardiac muscle tissue, the major vessels, and the pericardium surrounding the heart. Everything looked textbook normal. No bruising, no tears, no signs of the blunt force trauma that should have been evident after a 40-foot fall onto concrete. It was as if her internal organs had been completely protected from the impact that had supposedly caused her injuries. But the most disturbing discovery came when I examined the source of the mysterious fluid. In normal cases of pleural effusion, you can usually identify where the fluid is coming from: damaged blood vessels, torn lung tissue, or inflammatory processes that cause fluid to accumulate. In this patient, I could find no source whatsoever. The fluid seemed to have simply appeared in her chest cavity without any identifiable cause or origin point. "Dr. Park, I need you to send this fluid sample to the lab immediately. Request a complete analysis, including biochemistry, microscopy, and anything else they can tell us about what this substance actually is." The surgery continued for another hour as I meticulously examined every structure in her chest cavity, looking for any evidence of trauma or explanation for her condition. I found none. Her ribs were intact, her intercostal muscles showed no signs of damage, and her thoracic spine appeared completely normal on imaging. For a patient who had supposedly fallen through multiple levels of metal scaffolding, her internal anatomy was remarkably undamaged. By 1:15 p.m., I had completed the surgery and removed all of the unusual fluid from around her lungs. The patient's vital signs had returned to completely normal ranges: heart rate 72, blood pressure 118/76, oxygen saturation 98% on room air. She no longer required mechanical ventilation and was breathing independently with perfect respiratory function. I closed the surgical incisions and transferred her to the recovery room, but I couldn't shake the feeling that something was fundamentally wrong with this entire case. The mechanism of injury didn't match the clinical findings. The pattern of damage didn't conform to established medical principles, and the mysterious fluid I had removed from her chest defied any logical explanation. While the patient recovered from anesthesia, I decided to investigate the accident scene myself. During my residency, I'd occasionally visited trauma sites to better understand the circumstances surrounding particularly puzzling cases. Understanding the physics and environmental factors involved in an accident often provided crucial insights that helped explain unusual injury patterns or treatment complications. I drove to the construction site on Southeast Morrison Street where the accident had reportedly occurred. The site supervisor, Mark Davidson, met me at the security gate and walked me through what had happened that morning. She was working up on the third-level scaffolding, installing safety netting along the perimeter. Around 10:30, we heard this loud metallic groaning sound like the framework was under stress. Then there was a crash, and when we looked over, part of the scaffolding had collapsed and she was lying on the ground below. Davidson led me to the area where the patient had supposedly fallen. The scaffolding structure was indeed damaged, with twisted metal framework and safety barriers that had clearly given way under some kind of stress. But as I examined the scene more carefully, I began to notice details that didn't align with the story I had been told. The blood pooling that Tom Richardson had mentioned was visible on the concrete, but the pattern was wrong. Blood spatter from a high-impact fall typically shows directional patterns that indicate the angle and force of impact. This blood appeared to have been deposited in a more uniform pattern, as if it had dripped or poured rather than resulted from traumatic impact. More concerning was the absence of any personal belongings or equipment. Construction workers typically carry tools, wear hard hats, and have various safety equipment when working at heights. There was no sign of any personal effects in the area where she had been found. Mr. Davidson, did anyone retrieve her tools or safety equipment after the accident? That's the strange thing, he replied, scratching his head. We haven't been able to find any of her gear. No hard hat, no tool belt, nothing. It's like she just appeared there after the scaffolding collapsed. I asked to speak with the workers who had witnessed the accident, but Davidson explained that most of the crew had been working in other areas of the site and hadn't actually seen her fall. The few workers who had heard the scaffolding collapse had only discovered her after rushing to investigate the sound. Did anyone actually see her working on the scaffolding before the accident? I pressed. Davidson paused for a long moment. You know, Doc, now that you mention it, I'm not entirely sure. We had about 20 guys working different areas today, and I didn't personally see her up there. I just assumed she was part of the crew because she was wearing construction clothes and had the right safety gear when we found her. This raised immediate red flags. Construction sites maintain strict safety protocols and worker accountability. Everyone who enters an active construction zone must be properly credentialed, checked in with supervision, and assigned to specific work areas. The idea that someone could simply appear at a work site without proper authorization seemed highly unlikely. I spent another 30 minutes examining the accident scene, taking photographs and measurements. The more I studied the physical evidence, the more convinced I became that the official story didn't match the reality of what had occurred. The scaffolding damage looked genuine, but the patient's injuries and the circumstances of her discovery suggested something far more complex than a simple industrial accident. When I returned to Memorial General around 3:30 p.m., I found that the patient had regained consciousness and was sitting up in her recovery bed. She appeared alert and oriented, showing no signs of the confusion or disorientation typically seen in patients recovering from severe trauma and major surgery. Good afternoon, I said, approaching her bedside. I'm Dr. Chen. I performed your surgery this morning. How are you feeling? She looked at me with remarkably clear, focused eyes. Much better, thank you. The nurses tell me I had some kind of accident at a construction site, but I'm having trouble remembering exactly what happened. That's completely normal after a traumatic event and anesthesia. Your memory of the incident may come back gradually, or it might remain fragmented. Can you tell me what you do remember? She was quiet for several moments, appearing to concentrate on recalling recent events. I remember being in Portland, but I'm not sure why. I don't actually work in construction. I'm not sure how I ended up at that work site. This was highly unusual. Patients with head injuries sometimes experience retrograde amnesia, forgetting events immediately before their accident. But this patient seemed to have no memory of her recent activities or even why she was in Portland. Her cognitive function appeared completely normal, but her recollection of events leading up to the accident was entirely absent. What's the last thing you clearly remember? I asked. I remember being in San Francisco about a week ago. I was visiting the Museum of Modern Art, looking at an exhibition of contemporary sculpture. After that, everything becomes very unclear until I woke up here. The patient's account raised more questions than answers. If she had been in San Francisco a week ago with no memory of how she'd gotten to Portland or why she was at a construction site, then her presence at the accident scene became even more mysterious. I spent another 20 minutes talking with her, assessing her neurological function and trying to understand her situation. Her speech was clear and coherent. Her memory for events prior to the past week was excellent. She could recall detailed information about her education, her interests, and her personal history. But she had absolutely no recollection of the circumstances that had brought her to Portland or led to her being at the construction site. Most puzzling was her apparent lack of concern about her situation. Patients who wake up in hospitals after traumatic accidents typically experience anxiety, confusion, and distress about their circumstances. This patient seemed remarkably calm and accepting of her condition, as if waking up in a trauma center after major surgery was a perfectly normal occurrence. The results on the fluid I'd removed from her chest came back around 5:45 p.m., and they were unlike anything our pathology department had ever analyzed. The fluid contained proteins and cellular structures that didn't match any known biological material. The chemical composition included elements that shouldn't exist in human pleural fluid, and the microscopic examination revealed organized structures that resembled living tissue but didn't correspond to any recognized cell types. Dr. Chen, I've been doing pathology for 22 years, and I have no idea what this substance is, admitted Dr. Robert Kim, our chief pathologist. It's clearly biological in origin, but it doesn't match anything in our reference materials. I've sent samples to the state laboratory for more specialized analysis, but I wanted to give you these preliminary results immediately. The pathology report only deepened the mystery surrounding this patient. Not only had she survived a fall that should have been fatal with minimal apparent injuries, but her body had contained a substance that defied medical classification. Combined with her memory loss and the inconsistencies at the accident scene, this case was becoming the most perplexing medical situation I had ever encountered. As my first day as an attending trauma surgeon drew to a close, I realized that everything I thought I knew about trauma medicine and human physiology was being challenged by a single patient whose very existence seemed to contradict established medical principles. As evening rounds approached, I decided to review security footage from the construction site to see if I could piece together what had actually happened that morning. The site supervisor, Mark Davidson, had mentioned they kept digital recordings of the work areas for safety compliance and insurance purposes. With the patient's permission and proper medical authorization, I was able to access the relevant footage from the morning of the accident. What I discovered watching those recordings fundamentally changed my understanding of the entire situation. The timestamp showed 10:15 a.m., 15 minutes before the reported scaffolding collapse. The third-level platform where the patient had supposedly been working was completely empty. No workers, no equipment, no activity of any kind. The scaffolding appeared structurally sound with no signs of stress or impending failure. At 10:28 a.m., 2 minutes before the collapse, the camera angle still showed an empty platform. Then, inexplicably, the recording seemed to skip or jump forward several seconds. When the image resumed, the scaffolding was already collapsing, twisted metal falling toward the concrete below, but there was no sign of anyone falling with the debris. The next clear image was at 10:47 a.m., showing construction workers rushing toward the collapsed scaffolding area. And there, lying motionless on the concrete, was the patient I had operated on. She appeared to have simply materialized at the accident scene during the gap in the recording. I reviewed the footage multiple times, examining every frame for any detail I might have missed. The gap in recording lasted exactly 12 seconds, from 10:28:14 to 10:28:26 a.m. During those 12 seconds, an empty construction site had somehow produced a critically injured patient with no logical explanation for how she had gotten there. More troubling was the condition of the scaffolding itself. The structural failure appeared to be genuine, with support beams twisted and safety barriers torn away. But the pattern of damage suggested the collapse had occurred from internal stress rather than external impact. It was as if the metal framework had been subjected to forces that exceeded its engineering specifications, but there was no visible cause for such stress. When I returned to check on the patient around 7:30 p.m., I found her room empty. The bed had been stripped and cleaned, her medical chart was missing, and there was no sign that anyone had ever been treated there. I immediately contacted the nursing supervisor, Linda Martinez, who had been on duty when the patient was admitted. "Linda, where is the trauma patient from this morning?" "The young woman who had the chest surgery?" She looked at me with genuine confusion. "Dr. Chen, I don't know what patient you're referring to. We haven't had any major trauma cases today. Are you thinking of someone from yesterday's shift? That's impossible. I operated on her myself." "Room 314, the woman who fell from the scaffolding. You were there when she arrived by helicopter." Linda checked her records carefully, reviewing the patient log and surgical schedules. "Dr. Chen, according to our documentation, you performed surgery on a construction worker with a hand injury this morning, and then a motorcycle accident victim with abdominal trauma. There's no record of any helicopter transport or chest surgery today." I felt a chill run down my spine. Not only had the patient disappeared, but apparently all official record of her existence had been erased as well. The surgical notes I had dictated, the pathology samples I had sent for analysis, the helicopter transport records, everything had vanished as if the entire case had never happened. I rushed to the pathology department to speak with Dr. Kim about the fluid analysis he had mentioned earlier. When I found him in his office, he greeted me normally but showed no recognition when I asked about the unusual samples from my chest surgery patient. "Dr. Chen, I haven't received any samples from you today. Are you sure you sent something to the lab? I would definitely remember analyzing an unusual fluid like you're describing." Even Dr. Kim had no memory of our conversation about the mysterious substance I had removed from the patient's chest cavity. It was as if the entire medical team had simultaneously developed amnesia about a case that had consumed most of my day. I decided to drive back to the construction site that evening to verify that at least the scaffolding collapse had actually occurred. When I arrived at the Southeast Morrison Street location around 8:45 p.m., I found an active construction site with no signs of any accident or structural damage. Workers were operating normally on multiple levels of intact scaffolding that showed no evidence of recent repairs or reconstruction. The security guard at the site entrance had no record of any accidents, no knowledge of emergency responders arriving that morning, and no recollection of speaking with a doctor about an incident earlier in the day. According to him, it had been a completely routine workday with no safety issues or unusual events. Standing in the exact location where I had seen blood pooling and twisted metal just hours earlier, I began to question my own sanity. Had I imagined the entire case? Was I experiencing some kind of psychological breakdown on my first day as an attending surgeon? The stress of the new position, the pressure to perform, the fear of making mistakes that could cost lives, could all of that have combined to create an elaborate hallucination? But I knew what I had experienced was real. I could still recall every detail of the surgery, every anomaly in the patient's presentation, every inconsistency in her story. The memory of removing that strange, iridescent fluid from her chest cavity was as vivid and clear as any other surgical procedure I had ever performed. I returned home that night feeling more disturbed than I'd ever felt after any day of medical practice. The rational part of my mind wanted to dismiss the entire experience as stress-induced delusion or some kind of psychological reaction to the pressure of my new role. But the physician in me knew that what I had witnessed defied rational explanation. Over the next several days, I tried to investigate further, but every avenue I pursued led to dead ends. There were no hospital records, no ambulance transport logs, no helicopter flight records, no construction site incident reports. It was as if the entire case had been systematically erased from every database and every person's memory except my own. The most unsettling aspect was how everyone I spoke with seemed genuinely confused by my questions, rather than evasive or secretive. Dr. Torres, the trauma nurses, the pathology staff, the construction site supervisor, they all appeared to have no recollection whatsoever of events that I remembered with perfect clarity. Their confusion seemed authentic, which made my own memories feel increasingly isolated and questionable. I began to wonder if I was losing my grip on reality. Medical training teaches physicians to rely on empirical evidence, documented observations, and verifiable data. When all of that evidence disappears, how do you maintain confidence in your own perceptions and experiences? 3 weeks after what I had come to think of as the phantom surgery, I was working another day shift when something happened that changed everything once again. I was reviewing x-rays in the trauma bay when I heard a familiar voice speaking to one of the triage nurses. "Excuse me, I think I may have been a patient here a few weeks ago. I was hoping someone could help me understand what happened to me." I looked up from the computer screen and saw her. The same young woman I'd operated on, standing at the triage desk wearing civilian clothes and appearing perfectly healthy. She looked exactly as I remembered her, with the same dark hair and athletic build, but there were no signs of recent surgery or medical treatment. My heart started racing as I approached the desk. I wanted to call out to her to confirm that she was real and that my memories of treating her were accurate, but something made me hesitate. Instead, I positioned myself where I could hear her conversation with the nurse without being noticed. "I'm trying to piece together what happened to me about 3 weeks ago. I have some memories of being in a hospital, having surgery, and talking with doctors. But I can't find any medical records or documentation. It's like I dreamed the entire experience." The triage nurse checked the computer system thoroughly, running searches under various names and dates. "I'm sorry, but I'm not finding any record of you being treated here recently." "Are you sure it was Memorial General? Maybe it was a different hospital in the Portland area?" "I'm certain it was here." I remember the layout of the rooms, the view from the windows, specific conversations with medical staff. But everyone I've tried to contact has no memory of treating me. It's like I was never here at all. As I listened to her describe the same experience I had been struggling with for 3 weeks, I realized that both of us were dealing with the same impossible situation. She remembered being treated at our hospital with the same clarity that I remembered treating her. But all official evidence of the encounter had somehow disappeared. I watched her leave the hospital looking frustrated and confused, exactly how I had been feeling since that first day. But her appearance had confirmed something crucial. I wasn't losing my mind. The case had been real. The surgery had happened. Something or someone had systematically erased all evidence of her treatment, but they couldn't erase the memories from both of us. That evening, I made a decision that would ultimately lead to my resignation from Memorial General. I began documenting everything I could remember about the case, writing detailed notes about every aspect of the patient's presentation, the surgical procedure, the anomalies I had discovered, and the subsequent disappearance of all records. Also started researching similar cases in medical literature and news reports, looking for any other instances where patients and medical records had simultaneously vanished from hospitals. What I found was both fascinating and deeply disturbing. Over the past decade, there had been at least 8 documented cases at major trauma centers across the country where patients had been treated for unusual injuries, only to have all records of their care mysteriously disappear within days of their treatment. The pattern was remarkably consistent. Patients would arrive with injuries that defied conventional medical explanation, often involving substances or conditions that couldn't be easily categorized. Medical staff would provide treatment and document their findings, only to discover later that all evidence of the patient's existence had been systematically removed from hospital databases, laboratory records, and even security footage. In most cases, the medical personnel involved reported persistent memories of treating these patients, but they were unable to find any colleagues who recalled the same cases. The isolation and self-doubt experienced by these physicians often led them to question their own mental health and, in several instances, to leave their medical practices entirely. Most disturbing was the apparent coordination required to execute such comprehensive record elimination. Removing patient data from multiple hospital systems, laboratory databases, ambulance services, and security recordings would require access and authority that went far beyond what any individual or small group could accomplish. It suggested the involvement of organizations with significant resources and technical capabilities. I spent weeks trying to understand who might have the motivation and ability to systematically erase medical records and manipulate the memories of healthcare workers. Government agencies, pharmaceutical companies, research institutions. All of these seemed like possible candidates, but I couldn't determine why they would target specific trauma patients or what they hoped to accomplish by eliminating evidence of their treatment. The psychological toll of this investigation began affecting my ability to function as a surgeon. I found myself second-guessing every unusual case, wondering whether patients with atypical presentations might simply disappear from hospital records after I treated them. The doubt and uncertainty made it impossible to maintain the confidence and decisiveness required for trauma surgery. My colleagues began noticing changes in my behavior and performance. I was spending excessive amounts of time documenting routine procedures, as if I was trying to create an evidentiary record that couldn't be easily erased. I was asking unusual questions about hospital security protocols and data backup systems. I was reviewing cases multiple times and cross-referencing patient information with external databases. Dr. Torres called me into his office 6 weeks after the phantom surgery to discuss his concerns about my recent performance. "Sarah, several staff members have mentioned that you seem distracted and anxious during procedures. Your surgical skills remain excellent, but your decision-making process has become overly cautious and time-consuming. Is there something affecting your confidence or concentration?" I wanted to tell him about the disappeared patient, the erased records, and the pattern of similar cases I had discovered in my research. But I knew that describing these experiences would likely result in mandatory psychological evaluation and possible suspension from surgical duties. Instead, I gave him vague explanations about adjusting to the and death decisions. But responsibilities of being an attending surgeon and dealing Dr. Torres had been with the stress of making life practicing trauma surgery for too long to accept superficial explanations. He could see that something significant was affecting my ability to function effectively, and he was concerned about the potential impact on patient care. He suggested I take some time off to address whatever personal issues were interfering with my medical practice. That conversation forced me to confront the reality of my situation. I could continue practicing surgery while harboring doubts about the nature of reality and the reliability of my own memories, potentially compromising patient care. Or I could step away from medicine entirely and try to understand what had happened to me and why. The decision ultimately made itself when I encountered the patient one final time, 7 weeks after our initial meeting. I was leaving the hospital after my shift when I saw her sitting in a car in the parking garage, apparently waiting for me. "Dr. Chen," she called out as I approached my vehicle, "I was hoping I might run into you here." I stopped and looked at her carefully, still not entirely convinced she was real. "How do you know my name? I remember our conversations from when you treated me. I remember the surgery, the recovery room, everything we discussed about my memory loss and the accident. But I also remember that everyone else seems to have forgotten I was ever here." We stood in the dimly lit parking garage talking for over an hour. She told me that she had been experiencing the same isolation and confusion that had been affecting me. She remembered being treated at Memorial General with perfect clarity, but she couldn't find any evidence that the treatment had actually occurred. She had tried contacting other hospitals, thinking perhaps her memories were confused about the location. But none of them had any record of treating her either. More unsettling, she had also tried to return to San Francisco, where she remembered being before the accident. But she couldn't find her apartment, her job, or any of the people she remembered from her life there. It was as if her entire existence prior to arriving in Portland had been erased, along with the medical records of her treatment. "I realize how insane this sounds," she said, "but I'm starting to think that neither of us are supposed to remember what happened. Everyone else has forgotten. All the records have disappeared, but somehow we both still have these memories. Maybe we weren't supposed to retain them." Her words crystallized something I had been struggling to accept for weeks. The systematic erasure of evidence, the selective memory loss affecting everyone except the two people most directly involved. The coordination required to eliminate traces from multiple systems and databases. All of it pointed to an intentional cover-up by some organization with extraordinary capabilities. But if that was true, then the question became, what had we witnessed that someone was so determined to hide? What was so significant about her case that it required the complete elimination of all evidence? And why had our memories been left intact when everyone else's had been altered or suppressed? Standing in that parking garage, talking with a patient who shouldn't exist about a surgery that had no official record, I realized that my career in trauma medicine was effectively over. I couldn't continue practicing when I no longer trusted the fundamental systems and institutions that form the foundation of medical care. If patient records could be erased, if memories could be selectively altered, if entire medical cases could be made to disappear, then what was real and what was manufactured? The next morning, I submitted my resignation to Dr. Torres and the hospital administration. In my resignation letter, I cited personal reasons and a desire to pursue other opportunities outside of clinical medicine. I didn't mention the disappeared patient, the erased records, or the weeks of investigation that had led to my decision to leave surgery. Dr. Torres accepted my resignation with obvious disappointment, but without pressing for detailed explanations. I think he understood that whatever was affecting me was beyond the scope of normal workplace issues, and he respected my decision to step away from practice rather than risk compromising patient care. My last day at Memorial General was August 30th, 2019, exactly 6 weeks after what I had come to think of as the case that changed everything. As I cleaned out my office and said goodbye to colleagues who had become like family during my years of training and practice, I felt a profound sense of loss. Not just for the career I was leaving behind, but for the certainty and trust in reality that had been fundamental to my identity as a physician. I moved to a small town in rural Oregon and opened a family practice focused on routine medical care. Vaccinations, annual physicals, minor injuries, and chronic disease management became my new reality. It was a dramatic change from the high-stakes environment of trauma surgery, but it allowed me to practice medicine in a setting where unusual cases and mysterious disappearances seemed less likely to occur. But I never stopped thinking about that first day as an attending surgeon and the patient who had challenged everything I thought I understood about medicine and reality. Sometimes I wondered if I had made the right decision by leaving trauma surgery. Maybe I should have continued practicing and tried to document future anomalous cases. Maybe I could have helped other physicians who might encounter similar situations. Other times, I was grateful to have escaped from whatever system or organization had the power to manipulate medical records and human memories so comprehensively. The small-town practice where I worked seemed safely removed from the kind of high-level medical cases that might attract unwanted attention from powerful interests. 3 years after leaving Memorial General, I received a package in the mail with no return address. Inside was a single photograph showing the construction site on Southeast Morrison Street, but the image was taken from an angle that revealed details I hadn't noticed during my visits to the scene. In the background of the photograph, barely visible unless you knew what to look for, was a black sedan parked on a side street with clear sightlines to the scaffolding area. The car's license plate was too distant to read, but the positioning suggested surveillance rather than casual presence. More significantly, the timestamp on the photograph showed 10:25 a.m. on the morning of the accident, just 3 minutes before the scaffolding collapse that had brought the mysterious patient to my operating room. Someone had been watching the construction site, and someone wanted me to know they had been watching. The photograph haunted me for days. I studied every detail through a magnifying glass, trying to identify any other clues about who had been monitoring the construction site that morning. The image quality was professional, taken with expensive equipment from a considerable distance. This wasn't a casual snapshot or security footage. Someone had been conducting deliberate surveillance of the area where my mysterious patient had appeared. I began to wonder if the package was a warning or an invitation. Was someone trying to intimidate me into silence, or were they providing evidence to support my investigation? The fact that they had my current address in rural Oregon suggested they had been tracking my movements since I left Memorial General. That realization was deeply unsettling. Over the following weeks, I noticed subtle changes in my daily routine that made me increasingly paranoid about being watched. Cars that seemed to follow the same routes I took to work. Customers in the local coffee shop who appeared to be paying more attention to my conversations than to their own business. Phone calls that disconnected immediately when I answered. Small details that individually meant nothing, but collectively suggested someone was monitoring my activities. My family practice in Grants Pass had been a peaceful refuge from the intensity of trauma surgery. But now even routine medical encounters made me hypervigilant about unusual presentations or unexpected patient behaviors. Every time someone walked into my clinic with injuries that didn't quite match their story, I found myself wondering if I was about to encounter another case that would mysteriously disappear from all records. Dr. Martinez, the elderly physician who had owned the practice before selling it to me, occasionally stopped by to check on how things were going. During one of these visits, he mentioned something that immediately caught my attention. "Sarah, in my 40 years practicing medicine here, I've had maybe 3 or 4 cases that still puzzle me. Patients who came in with conditions I couldn't quite explain, and then when I tried to follow up with them later, it was like they had never existed. No forwarding addresses, no other medical records anywhere, nothing. I tried to keep my expression neutral, but internally I was fascinated. Had similar mysterious patients appeared in small-town practices as well as major trauma centers? Was this phenomenon more widespread than I had realized? Can you tell me more about these cases?" I asked, trying to sound casually interested rather than intensely curious. "Well, there was a woman about 15 years ago who came in with what looked like chemical burns on her hands and arms. But the pattern was unlike anything I had seen in textbooks or during my training. The burns seemed to follow specific geometric shapes, almost like symbols or markings. When I asked her how it happened, she said she couldn't remember. The burns healed remarkably quickly with basic treatment, but when I tried to schedule a follow-up appointment, the phone number she had given was disconnected and the address didn't exist." Dr. Martinez continued describing the other cases, and each one followed a similar pattern. Unusual medical presentations that defied conventional diagnosis, patients with gaps in their memory about how their conditions had developed, and subsequent disappearances that left no trace of their existence. The most intriguing case he described had occurred just 2 years before I arrived in Grants Pass. A middle-aged man had come to the clinic complaining of severe headaches and vision problems. When Dr. Martinez examined him, he found that the man's pupils were reacting to light in ways that didn't conform to normal neurological responses. His eyes would dilate and contract in perfect synchronization, but not in response to changes in lighting. It was like they were responding to some other stimulus that I couldn't detect. I referred him to an ophthalmologist in Portland, but when I called to follow up, they said he never showed up for his appointment. When I tried to contact him directly, all the information he had provided turned out to be false. These accounts from Dr. Martinez confirmed my growing suspicion that mysterious patients were appearing at medical facilities throughout the region, not just at major trauma centers. The pattern was consistent: unusual medical presentations, memory gaps, and subsequent disappearances with no trace of their existence in official records. I decided to start documenting every unusual case I encountered in my own practice, creating detailed notes that I stored in a secure location separate from the official medical records. If patients or records were going to disappear, I wanted to maintain an independent record of what I had observed. My opportunity to test the system came sooner than expected. On a rainy Thursday morning in October, a young man in his early 20s came to my clinic complaining of fatigue and muscle weakness that had developed over the past week. He appeared healthy and athletic, but his description of his symptoms was concerning. "Doctor, it's like my strength is just draining away. Last week, I could lift weights and run for miles without any problem. Now I can barely climb a flight of stairs without getting winded. But I haven't been sick, I haven't changed my diet or exercise routine, and I haven't been taking any medications." I began a thorough examination, checking his vital signs, listening to his heart and lungs, and testing his muscle strength and reflexes. His vital signs were completely normal. Heart rate, blood pressure, temperature, and respiratory rate were all within perfect ranges. But when I tested his muscle strength, I found significant weakness that seemed to affect his entire body uniformly. More puzzling was the quality of his muscle tone. When I pressed on his arm and leg muscles, they felt different from normal muscle tissue. Less dense, almost hollow, as if the muscle fibers themselves had changed in composition. I had never encountered anything like it in my medical training or practice. "What's your name?" I asked, preparing to document the case in both the official record and my private notes. He paused for a moment, as if he had to think about the answer. James Wilson." The hesitation was subtle, but noticeable. Most people respond immediately when asked their name. It's such a fundamental piece of personal identity that the answer should be automatic. His brief pause suggested he was either very confused or possibly providing false information. Where are you from originally, James? Another pause. Seattle, I think. Or maybe Portland. I've moved around quite a bit recently. His uncertainty about basic biographical information was another red flag. Combined with his unusual physical symptoms and the strange quality of his muscle tissue, this case was beginning to feel familiar in all the wrong ways. I ordered blood tests to check for various conditions that could cause muscle weakness and fatigue. Thyroid disorders, autoimmune conditions, vitamin deficiencies, and infectious diseases all needed to be ruled out. I also scheduled him to return in a week for follow-up examination to monitor any changes in his condition. The blood test results came back 3 days later, and they were completely normal. Every parameter was within the standard reference ranges. His blood work showed no signs of infection, inflammation, metabolic disorders, or nutritional deficiencies. From a laboratory standpoint, he appeared to be perfectly healthy despite his reported symptoms and the physical findings I had documented. When James returned for his follow-up appointment the following week, I was prepared to find either improvement in his condition or progression of whatever was causing his muscle weakness. What I found instead was something I hadn't anticipated. James appeared to be in perfect health. His muscle strength had returned to normal, his energy levels were back to baseline, and he showed no signs of the fatigue and weakness that had brought him to my clinic just 7 days earlier. When I tested his muscle tone, it felt completely normal, with none of the unusual hollow quality I'd noted during his initial examination. How are you feeling today, James? Much better, doctor. Actually, I feel great. I'm not sure why I was so tired last week, but whatever it was seems to have resolved completely. His recovery was medically remarkable. Most conditions that cause significant muscle weakness take weeks or months to resolve. Fact that a treatment, the even with appropriate, had returned to normal function in just 1 week, without any intervention, suggested that whatever had been affecting him was unlike any standard medical condition. More concerning was his apparent lack of memory about the severity of his symptoms during our previous encounter. When I reminded him that he had been unable to climb stairs without becoming winded, he looked genuinely puzzled. Really, I don't remember it being that bad. I thought I was just feeling a little run down, maybe needed more sleep or better nutrition. I spent another 20 minutes examining him and asking questions about his symptoms and recovery. His responses consistently minimized the severity of his previous condition and suggested that his memory of our initial consultation was either impaired or had been somehow altered. After James left the clinic that day, I immediately went to my computer to review the detailed notes I had made about his case. I wanted to compare his current presentation with the specific physical findings and symptoms I had documented during his initial visit. The notes weren't there. My detailed documentation of his muscle weakness, the unusual quality of his muscle tone, and his uncertainty about basic biographical information had been completely erased from both the electronic medical record and my private documentation files. The only evidence that he had ever been treated at my clinic was a brief entry, noting a routine visit for general fatigue that had resolved spontaneously. Even more disturbing, when I checked the laboratory database for his blood test results, there was no record that any tests had been ordered or performed. The comprehensive metabolic panel, complete blood count, and thyroid function studies that I clearly remembered ordering had apparently never existed. I sat in my office staring at the computer screen, feeling the same sick sense of disorientation I had experienced after the trauma surgery case at Memorial General. Once again, my detailed memories of treating a patient were contradicted by the complete absence of any official documentation that the treatment had occurred. This time, however, I was prepared. Before seeing James for his initial consultation, I had taken the precaution of writing brief handwritten notes about unusual cases and storing them in a locked file cabinet in my home office. When I checked this backup documentation system that evening, I found that my handwritten notes about James Wilson were still intact. The notes confirmed what I remembered about his presentation: significant muscle weakness affecting his entire body, unusual muscle tone that felt hollow or insubstantial, hesitation when providing basic biographical information, and blood test orders that had apparently been erased from official records. Having physical documentation that couldn't be digitally altered gave me confidence that my memories were accurate and that some external force was systematically removing evidence of these unusual medical encounters. But it also raised terrifying questions about the scope and sophistication of whatever organization was capable of such comprehensive data manipulation. If they could alter electronic medical records, laboratory databases, and even digital documentation stored on secure hospital servers, what other aspects of reality might they be able to control or modify? How many other physicians were experiencing similar cases without realizing that their memories were being contradicted by deliberately falsified records? I began implementing additional security measures for documenting unusual cases. Handwritten notes stored in multiple locations, photographs of patients and physical findings when appropriate, and audio recordings of consultations stored on devices that weren't connected to any network or database system. My paranoia was vindicated 3 weeks later when I attempted to access my private documentation files and found that someone had broken into my home office. Nothing appeared to be missing, but the locked file cabinet where I stored handwritten notes about unusual cases had been opened and the contents had been photographed or copied. That break-in was the final confirmation I needed that my experiences were real and that someone was actively monitoring my activities. I moved away from medicine entirely and now work as a medical consultant for insurance companies, reviewing routine claims and staying as far away from unusual cases as possible. But I still wonder how many other physicians have encountered patients like mine, and whether they even remember treating them. Sometimes I think about that mysterious fluid I removed from my patient's chest, the photograph someone sent me, and the woman who appeared and disappeared like a ghost. I may never know what I witnessed that day, but I know it challenged everything I believed about medicine and reality. If you're a healthcare worker and you've experienced something similar, you're not alone, and you're not losing your mind. Some mysteries are meant to stay hidden,